My name is Emily Auwarter, and I am MPH Epidemiology and Biostatistics candidate at Boston University School of Public Health. And this summer for my CEESP fellowship field practicum, I had the pleasure of going to Cairo, Egypt, and spending weeks of my summer there conducting a multi-center study. So I'll explain further on where two of my study sites are, but it's a comparative brain and central nervous system tumor incidence and survival analysis between the Dana-Farber Cancer Institute in Boston and that of the Children's Cancer Hospital of Egypt. So just before I get into all the logistics, a little background on pediatric cancer. It's a leading cause of malignancy among children, including morbidity worldwide. About 175 cases have been documented in 2016, and that number is anticipated to increase within the next 5 to 10 years. Given the most common form of pediatric cancer is acute leukemia, as some of you may know. However, what my project focuses on is the second most common form, which is central nervous tumor, in other words, brain cancers. It represents 1/5 of all diagnosed pediatric cancers worldwide, and an interesting portion of this type of tumor is that most of the research that I have in the literature is from high-income thriving countries. So we know a little bit about the epidemiology and the survival rates of this type of tumor within the low middle-income countries. So kind of piggybacking off that idea, a large portion of my study that I'm interested in addition to the pediatric cancer side of things, is that gap between high-income and low middle-income countries, and how can we close that gap through access to the medical treatment you need and proper diagnosis. So 85% of the childhood cancers, as an umbrella, are diagnosed in developing countries, and almost 50% of that is central nervous tumors. And as it's a significant health problem, the burden of disease is increasing due to more exposure to risk factors among these children in these impoverished areas, limited access to the proper technology and personnel. So simply, the pediatric oncology field is not a very popular field in these low middle-income countries, which represents a low patient-to-physician ratio in many places. So just a didn't know I put those in there. There we go. So just before I move forward, the two that I decided to focus on, considering that central nervous tumors is a big field, are the most prevalent. So ependymomas and medulloblastomas are the two most common brain cancers. And they're also the most prevalent in the hospitals I was working at. So ependymomas, a little bit about the background, is they represent about 6 to 12% of all diagnosis, and they occur 4 to 6 years of age. You'll generally see these diagnoses in the brainstem, and they'll go downward through the cervical spine and sometimes further. Prognostic factors, so what improves survival is the extent of resection. The importance of that first surgery of getting all that disease removed increases the survival from 11 to 66%. So that is crucial for these children. Also, the younger the age, the more negative the impact of survival, as well as, however, if they're diagnosed with a solely focal spinal cord ependymoma, that increases their survival. Jumping to medullos, this accounts for about 1/5 of the central nervous tumors, and they occur a little earlier in life, sometimes peaking at 2, but generally 3 to 4 years. And that spreads generally through the ventricles of the posterior fossa, which is in the midbrain of the brain. The prognostic factors are generally the size of the tumor. So a smaller tumor, greater survival; larger tumor inhibits that survival. And like I said before, the gross total is also just as important in medullos, increasing survival from 12 to 15% once you get that gross total resection. Oh. There we go. So as I stated, it's a multi-center study. This is a big learning experience for me, as I will never have proposed a study on my own, but never have I done a study in 2 different centers. So I started in Dana-Farber early this spring. And then this summer I lived in Cairo. So this whole study is evaluating this newly collaborating relationship that was built about 5 to 7 years ago between these two hospitals. And Children's Cancer Hospital was built in 2007, so it's a new hospital. It's still growing, it's still evolving, and it relies heavily on this relationship with Dana-Farber to bring in their protocols, adapt some new ideas with clinical trials, that kind of thing. So this whole study background idea is evaluating this relationship between a high-income thriving hospital and that of this low-middle-income thriving country hospital, which just started. And how well is the survival doing? Is this relationship working? Are there holes in it? Are there flaws? And I'm kind of going in and evaluating that. So a little more about the Dana-Farber. My mentors pictured in the center. Here is Dr. Peter Manley. He's a certified pediatric neuro-oncologist, as well as I'm working with Dr. Karen Marcus, who's the head of the radiation department. One of the good things about Dana-Farber is their affiliation with Boston Children's. So the Dana-Farber is a research institute. They do have outpatient centers. However, a majority of their children that they treat are inpatient stays at Boston Children, which is a 415-bed hospital, and they calculate about 700 new brain tumor cases a year. And then stemming a little bit about the hospital where I was this summer was the Children's Cancer Hospital of Egypt, which is located in the heart of Cairo. And it, like I said, was built in 2007, and it's one of the largest nonprofit hospitals in the world, housing 320 beds. However, in the next 3 to 5 years, given their timeline, and Egypt timeline can be a little off from what I hear, they will have double that, and it'll be a 640-bed hospital within the next 3 years, they're hoping. But it is accumulates about 1,700 brain tumor cases a year, and pictured to the right here is my advisor that I worked with closely, Dr. Muhammad Dalou, who's the head of the radiation department of oncology. And one of the things to note about this hospital is solely pediatrics. So they only treat children under the age of 18, and they only treat children who are referred from an outside physician, and it's their first primary diagnosis. So one of the good things about my data, I'll address this in my strengths, but is that every record I looked at, their record started in this hospital and it ended in this hospital. Okay, so study objectives. What I was looking for overall is the first thing I want to look at, stratified by disease, are the age-adjusted incident rates. So I want to look at, is there a certain age that we see a more increase of these brain tumors, and also does that affect the overall survival? The majority of my project is based on the overall survival, and I want to look at, is there a difference in these survivals, and what type of treatment, if there's a change in protocol that attributes to this change in survival between Dana-Farber and Egypt. Moving further, I also want to look at the association of clinical factors. So I want to look at, obviously, the difference in institutions. I want to look at a difference in age. Is children diagnosed before 3 compared to children diagnosed at 14? Is there a difference in survival? And most importantly, my project relies heavily on the type of treatment. So the protocols that they're using in Egypt are slowly changing, and I want to see if there's a certain type of protocol we use in Dana-Farber that can be adapted in Egypt to improve their overall survival. Just a general idea of my study population, I did a retrospective cohort, and I chose children between the years 2007 and 2012, so at the start of the Children's Hospital, and I followed them through to 2016. So all the time and all the data points that I accrued were through that time period, and I noted any type of important outcomes. So I looked at death, loss of follow-up, remission, and then my end of study. So the method section. So my data collection was extracted from 2 separate hospital-based registries. Dana-Farber, I utilized their hospital-based system PowerChart, which is a Cerner-based hospital system, to find my information. I worked solely on my own at Dana-Farber, and once I had my information, I'd bring it to my PI, Dr. Manley. He would cross-check my information, and if I had any other question about missing information, I would solely rely with him. So it was kind of a 2-person relationship working at Dana-Farber. For the Hospital of Egypt, I worked really closely with the clinical research team. They were kind of like my greatest friends at the hospital, because I wouldn't have been able to do all these records without them. Overall, Dana-Farber, I collected about 100 records for both tumors between that year, and with Egypt, we collected over 330. So definitely 330 records going in and looking at the records were both paper and electronic. So it was really important having someone from the hospital who was understanding of Arabic to help me translate some of the records and put that into my database, which was then analyzed in REDCap. This was my first time using REDCap, and I'm really happy I did use it because it was easily accessible given my multi-center study, so people in Dana-Farber could readily go in and check my data, as well as people in Egypt. So we all had access to this and make sure that the data was going in promptly and correctly. And then obviously for my data analysis, my REDCap was then used for my SAS statistical analysis, which will be presented a little later. So my initial results from my project, this is very preliminary. I'm still missing about 30 to 50 patients just due to missing data. Surprisingly, the missing patients are coming from Dana-Farber and not Egypt, which has kind of flopped in my original plan going into the summer internship. Just a little background, I collected 100% of my data, I lied, 98% of my data from Egypt. So it was phenomenal work on behalf of the research team and myself and with the PIs. We worked really hard to get all the information we needed. And in the end, I have about 15% missing from Dana-Farber. So who could imagine that? But my initial results, basically this is just some demographics and disease characteristics. I have generally across the board, medullos are on the right, ependymoma is on the left. I calculated follow-up time, which in general was 6 years. And when we look at any type of significance here, the most important was in the medullos, among the history of familial cancer and the type of treatment. The one thing I do want to note about the ethnicity and race, so in the United States we have a standardized way of classifying ethnicity and race. However, in Egypt they don't classify, or they don't separate it out into categories. So it's all classified as one. So my data for that is inadmissible, and moving forward I might choose to opt out this part of the study just because it's not really doing anything much if I don't have it for Egypt. Moving forward, I also ran a univariate to evaluate the overall survival rate in respect to these clinical factors. Like I said, I'm hoping to these, from my log rank, that they'll adjust somewhat once I add some more of the data in from some of the patients. However, right now we see significance still in the type of treatment, and also a little bit of the history of familial cancer, and I do want to look more at the age of diagnosis, given that the type of treatments I use vary depending on how old the child is. But most importantly, this is kind of what I really wanted to focus on was my overall survival curves. You can see here that Dana-Farber is in red, and they are varying between medullos 94% and 80% towards the 10-year survival. However, Egypt is significantly lower. This was the greatest significance I found in my study so far, and it's good results for me. However, when I had a discussion with my PI in Dana-Farber, they thought this was good. In Egypt, they didn't believe this. They thought they should have been a lot higher. So it was a very interesting conversation when one PI is like, oh, this is good, and the other one's like, this is awful. So it's a little awkward of a conversation. So moving forward, there's a little hostility, but we're going to try to all work together. But no, this is really good. For me, I personally thought that Egypt was going to be lower, and this gives me reason moving forward to now really look at the holes. Why is this lower? I have a lot of information collected on the type of radiation dosage, the type of surgeries they did, the number of surgeries, the type of chemo they did. And we're going to compare those protocols in a further analysis and hopefully dig down to the deeper reason why there's such a gap in the survival. So a lot of my learning curves come from the strengths and limitations of my study. At the Children's Hospital in Egypt, like I said, at the door they come in, they were diagnosed within a week, within a month. So it was their primary diagnosis, and every child is followed through completely. It's also a large neuro-oncology patient population, so I have a lot more cases coming from Cairo. And the research department was wonderful. I had a great working relationship with them, and they were really able to help me understand these records, as I had never worked with paper records before. So that was a very new experience for me, very one I'm happy to have under my belt now. And also they're familiar with REDCap. It worked very well with Dana-Farber. The limitations that I found, the records were both paper and electronic. So if it wasn't in the database of the electronic system, then we had to go to the paper records. And the one thing to note is that the radiation department I was working at has a separate paper database. So if it wasn't in the electronic system and it wasn't in the paper system of the hospital, then I had to go to the radiation department and say, hey, can I have your paper records? And since they opened, they still haven't made a unified record system yet, and they're moving towards that, I believe. But that's another study, that's another time. But that was definitely a limitation for timeline on my part. So, and also something to note is my original study included a neurocognitive piece, as I'm very interested in neurocognitive delays in respect to radiation. However, when I showed up in Egypt, there's no neurocognitive study, there's no department. Well, there's a department, but they don't study any type of neurocognitive effects that come from cancer treatment. So that was kind of my study on that part. Also the limited staff. So Egypt is this hospital is very understaffed. I remember walking in when I was doing consults one day, and I walked into the radiology room where they do all the screenings for the MRIs and the CTs, and they have one head radiologist and 2 fellows for the whole entire hospital. And they treat 500 to 700 kids outpatient a day, including a number of scans, and they have 3 people reading these scans. So that just kind of puts in perspective. At Dana-Farber, there's at least 10 radiologists per the little pediatric neuro-oncology unit. So just to give you a little perspective in that angle, speaking with the doctors, not many doctors want to get into pediatric oncology. It's not as fun, it's not as thrilling. The research isn't there, from quote on what I hear. I think it is, but and that just kind of goes to show the patient provider. So in a hospital of Egypt, there's 1 doctor to about 15 to 20 patients. Dana-Farber, it's about 1 to 5. And moving on to strengths of Dana-Farber, all records were electronic, small patient provider, as I said, it's about 1 to 5. And there is a neuropsychiatry department, so studies are heavily based on neurocognitive delays in respect to radiation, in respect to chemotherapy. Some limitations is there's a small patient population. I would have liked more cases, but I couldn't really do much about that. There's 2 record systems as well, so we don't only just use PowerChart, but we use Epic as well. So if it's not in PowerChart, then I don't have access to Epic. I had to go through someone who had to go to Epic, who had to go here. So that was a little bit of a skewed journey to get some records, which I would never have thought at Dana-Farber, at this thriving cancer research hospital, but it was harder to get than Egypt. And there's a large number of patients that are missing as well. So since Dana-Farber can get people that come in and out, sometimes they had to go in different files to get scan records from a treatment they had in Mississippi, where they went home for a treatment and they came back. So just kind of maneuvering my way around. Moving forward, as I said, my future analysis, I want to complete my Kaplan-Meier, so the survival curves, and go into more detail about the treatment regimens. So look more into radiation dosage, look more at the number of chemotherapy cycles these kids have, and especially look at proton versus photon, as I have a strong interest in the radiation side. I want to look at some Cox proportional hazards and progression-free survivals. But more importantly, future studies for possible students moving forward is an additional comparative study looking at a new cohort. So piggybacking off the data I have and now looking at 2012 to 2015 or 2017, as I spoke with my PI in Egypt, was really interested to see if the changes they've made so far has further improved their survival, and as this relationship builds with Dana-Farber, is this really working, and can these relationships be open to outside hospitals and outside countries? And also, it would be interesting to have someone who's interested in neurocognitive approach, kind of evaluate or implement what goes on in the Egypt hospital. Is this something that can possibly be started? I know they want to, but no one's interested in it, or they're just too busy. So it would be interesting to kind of get the ball rolling, as that's an important aspect. So my future career goals, possible career opportunity at Dana-Farber actually opened up, and this past weekend I accepted a position at the clinical research department. So I'll be working where my fellowship was, and that just kind of came about this past weekend, which is really exciting. But following that position, I would like to pursue an MD or PhD. I need some time to figure out, do I want to stick research, do I want to stay clinical? But I know for personal reasons I want to stay in pediatric oncology, and if I could stay in pediatric neuro-onc, that would be fabulous. And just to summarize with little pictures of my journey in Egypt, I met a lot of people all over the place. So from people that drive me on the boats, to the jewelers, to the little patients here. The selfies with my PI and Dr. Solomon. Had to throw that in there. So the people I met over there were absolutely wonderful and so accommodating, and made me feel so welcome. And this is just a little tidbit of my day in the office. The top right is my office in Egypt, and the bottom right is in Dana-Farber, so not too much of a change visually. And then this is my research crew that I worked with day in and day out. They were phenomenal, and this is our department. When we had meetings, I would move up to the research department and go from there. And then when I wasn't in there, I was exploring, and of course standing on camels, because that's very safe. but don't try it because you fall. But yeah, so that's my presentation, and if you have any questions, please ask.
I should say that all this hard work and travel and tourism was just in 2.5 weeks. No, not 2.5 weeks, right? 6 weeks?
Yeah, or something like that, yeah. So.
Great job. Questions, comments? So, Emily, what about the epidemiologic and demographic risk factors? I see that you're going to include only treatment factors for looking at the survivorship, but there are other factors that could be influencing the differences in survivorship.
Yeah, so, well, I was really hoping to kind of look more at the demographics side of things. However, that was kind of halted when there's no, they don't separate that really in Egypt, so it's all kind of one demographic. The only way I have data on geographic region, if that could attribute. However, my project, we solely looked at the treatment side of things, but moving forward, that is definitely something to look further into, is the demographic side of it, if there's a way to separate out in Egypt. We have it separated out in Dana-Farber, but we still haven't found a way to kind of separate that out.
Let's talk about that, because we get information about your research, go more in depth with demographic, not just region. The other issue is the pediatric oncology community in Egypt is critical of this hospital because this hospital selects the early stage cases. So this is going to be interesting to see, even with the biased sample of early stage cases, that they don't have survivorship equal to the U.S. survivorship.
Yeah, so it's a complicated study, but it's one that's brought about really interesting results for the hospitals. So it's a lot giving back to these two hospitals, and hopefully what we find, given this relationship, we can move that outward and expand that. But one thing I did mean to say is for one of the future studies would be interesting is to look at the NCI Cairo in respect to this hospital. As I did a high income to a low income, however, to be more generalizable, I think it'd be important to go into the NCI Cairo and the Egyptian database, or the Egyptian registry, and kind of include that as a comparative.
You said you're going to calculate incidence. How are you going to calculate incidence?
For just the age incident rates for both the Dana-Farber and for the Children's Hospital, just with the data we have. We haven't calculated it yet because we need to go through some of the data. It's not calculated as of yet because some things are missing, but it will be calculated.
Okay.
I wanted to ask about the relationship between Dana-Farber and the Children's Hospital in Egypt. And is it a collegial, collaborative relationship now, or I mean, do they? It would be nice to have both people in the game together, you know, and looking at stuff. That's number one, because I think from what you said, there's a lot of things Dana-Farber can learn from Egypt. I mean, in fact,
so
the records are easy to get at, you know, and we often think it goes one way, and it doesn't. No. There's so much stuff what one can learn from each other. So how could one make Dana-Farber aware of that and make Egypt aware of that? I mean, Egypt sounds like they're upset because the curve looks worse, but you know, it may be another way to frame this particular thing. But one of the things that we do where I live in the United States are these collaborative projects with other institutions around certain illnesses like cardiac disease or cystic fibrosis, and it turns out if a kid with the same stage of cystic fibrosis walks into a certain hospital in the United States, they get better care, and they have better outcomes, and it's all in the process of what they do, you know, right? And the same thing happened with cardiovascular disease. You know, if one has cardiovascular disease and is operated at this particular institution has a certain rate, and at this institution has another rate, even though they had the same characteristics, you know, it's all in the processes of what they do. And so if Dana-Farber and the Children's Hospital in Egypt were in a truly collaborative research project where they weren't competing, but they were learning from each case to sort of how to do better and looking at the process of what, you know, what happens when the kid comes in to get, you know, how many days does it take to get this, and you know, and what are risk factors that make for bad outcomes. And, you know, then the water for all the boats would raise. You know, that the water from Dana-Farber would raise and the water from Egypt would raise. And that type of collaborative thing might be different than just looking at the static data of what's happening to people right now and looking at the dynamic data of how do you take that and make it even better for the next kid that comes in with this particular illness. You know? Anyhow, that's just another thought of reframing the stuff and really getting, it would be really nice if people really collaborated. You know?
Yeah, there's definitely, the collaboration is definitely there and both sides are open to hearing each other. However, there is some, you know, not animosity I would say, but some hesitation in certain things. So some don't agree with others, and when you're working in, you know, two separate hospitals that are world renowned, they have all this information and all, you know, this research, they have their viewpoints. But I think that this relationship has been about 7 years now that they've been working, and they've just actually pronounced a fellowship that they're starting. So they send every 4 months they send people from our department over to the hospital, and it's been a very interesting relationship and an interesting project to work on. So,
Other questions, comments? Bob?
Well, it occurred to me that based on your comment that they handpick in Egypt early stage pediatric cancers, this throws everything off. So if you've got downstaging going on in the population, if Ministry of Health clinics are identifying these kids earlier and they go to this particular hospital, the curve's going to rise in that particular hospital. So I don't know how to get a handle on that. Where did the late stage patients go?
NCI Cairo, downtown?
Yeah. Well, like where do they go for treatment? Yeah, no,
Yeah.
A lot of the portion I was able to go to NCI Cairo, and since the 5737 is very selective, all the kind of the flow over patients will go to NCI Cairo in their pediatric department. So
I think you're going to mention that this is comparison between the two hospitals. It's not representative of Egypt. And I think part of the issue here, why you have some differences in survivorship, is what you talked about with the neurocognitive assessment. And we talked about this.
Yeah.
Taking care of the kids. It's not just treating and giving chemotherapy, brachytherapy. What's happening after chemotherapy and brachytherapy? This child is going home or going to a school. And survivorship is a multifactorial process. It's not just the chemotherapy and brachytherapy. Thank you, Emily.